features, therefore across the lifespan. And the learning objectives are, first of all, to consider the potential impact of this newish kind of concept. I'm really glad that it was brought out in DSM-5 with mixed features on patients' well-being and treatment decisions, both in the pediatric and the adult space. And number two, to collaborate with interprofessional teams and patient informants to improve the recognition of mixed features in patients with depression in order to avoid undesired consequences and improve patient outcomes. Usually the lesser of the two pieces of the mix is what is missed unless you explicitly go for it. Because if mania slaps you in the face, you then don't tend to see the depressive features and vice versa. And thirdly, to integrate treatments with evidence-based efficacy. Although there's no approved treatment, there still is evidence. And there's not only evidence-based prescribing, but as you know from the NEI kind of culture, there's also prescribing-based evidence, so that where empirically you find out what works. It's both in pediatric, mixed, unipolar, and bipolar.
Thank you, Dr. Stahl, and what a wonderful opportunity to talk to you about getting mixed up with someone who's been doing this observation of how we're prescribing in a field where you don't have FDA approvals, and seeing DSM evolve over the many versions.
Are you saying I've been mixed up for a long time?
We're just, we're getting warmed up here. But what I wanted to say is that I appreciate the dimensionality of the way we present the mood spectrum, because nature doesn't carve themes just so cleanly, and we recognize that as human beings we're experiencing a lot of symptoms that are on a continuum, and this is extremely validating for our patients to hear from us that we understand that things aren't always clear cut. So mixed features can actually be an entry into more empathic care for our patients, and this diagram and the ways that you've illustrated the mood spectrum, Dr. Stahl, over the years has been really helpful for me as an educator, but also as a clinician. I think that patients really value this continuum formulation. We've used categorical classifications for years. It's how we diagnose patients, but in practice, it's really more on a dimension. And individuals with unipolar depression who experience just a smidge of mania are going to have a more likely risk for developing bipolar down the line, but you won't have that index of suspicion if all you think they have is this monochromatic depression. So you think it's unipolar depression, but about a third of patients or more are eventually re-diagnosed with bipolar disorder. We recognize that bipolar disorder can often take up to a decade or more of being diagnosed. And almost 2/3 of patients with bipolar 2 are diagnosed with unipolar depression first. It's often the first episode. And even subthreshold mania symptoms are strongly associated with that conversion. So we talk about it kind of in the thirds rule of nature. Seems like lots of things fall into that thirds rule. 1/3 feel better, 1/3 stay about the same, 1/3 get worse. Well, similarly, you see these patterns of segregation where hypomania symptoms can actually increase your risk of developing bipolar disorder by a third. So how can we appreciate or understand this? And I think the clues come from a variety of different sources. As a clinician over the last 20 years, I think a good clinical history is usually the foundation, and I've been studying offspring of parents with bipolar disorder for almost 20 years now, recognizing that familial risk can actually predispose people pretty clearly. An early onset of a depressive episode makes a strong case. It's why I'm here to talk to you about mood disorders on the continuum over the lifespan, because a lot of the kids I see in clinic are experiencing mixed features. It's almost as if before you actually get to a definitive diagnosis, there's a roughening, and that happens over the course of development. So that clinical history, the retrospective understanding, if all you're seeing is adults, is that kids that I used to experience these subthreshold manias a lot as a kid, can be very insightful for your diagnostic evaluation. numbers of hospitalizations, the more you have, the rapid onset of depressive episodes, the more severe they are, all clues. And frankly, your experience with treatment can also clue a clinician in terms of how bad the response to a particular antidepressant. We used antidepressants as our first-line treatments for depression until we realized, whoops, we didn't screen for mania or hypomania first. Anytime you're prescribing an antidepressant, ask about mania and hypomania so that you're not missing a potential bipolar diagnosis. And frankly, it's hard. So I want to have some empathy because sometimes we get it wrong and we sometimes miss the hypomania that actually is precipitated by an antidepressant, but that's also important as a clue. And there's some other symptoms that kind of also play a role that we'll talk a little bit more about in a few minutes. So, keeping track that an early age of onset and a subthreshold hypomania can be kind of really, really critical clues. We focus a little bit more now on depression or depressive disorders with mixed features. So we're going to call that DMX throughout the presentation. You guys have heard these concepts before, but I think Dr. Stahl is right. Mixed features is a relatively new concept in clinical practice. We've almost ignored it, like we've ignored trauma. Over the years, we've sort of said, yeah, you've got these other things going on, but let's just treat the depression. And so, again, it's helpful to know what are mixed features associated with, so you can have those clinical clues in mind, and you can see here, as we discussed in the pre-test, a younger age of onset, longer duration of illness, poorer prognosis, and more severity as well as comorbidities can play a specific role. It seems to be more sex differentiated to females, and really the prognosis of a depression with hypomania features is much worse than straight up bipolar or straight up unipolar depression without any mixed features. And, symptoms most commonly seen are, again, irritability, distractibility, psychomotor agitation. These are the characteristics of mixed features, racing thoughts. You might think this is just mania or mania on a continuum, and that's exactly right. If you think about the secondary symptoms after you get an index mood of euphoria, elevated mood, or explosive irritability, the secondary symptoms are represented here: decreased need for sleep, or talkativeness, or emotional ability, rumination. The risky behaviors that come with mixed features. These are all signs pointing to that there might be some mania in the mix with depression, and we need to characterize it better. And what's interesting is that most symptoms seen in DMX or depression with mixed features kind of can be ranked in terms of frequency, with psychomotor agitation being the most prevalent and frequent, along with racing thoughts or flight of ideas. These are in and of themselves pretty nonspecific, but when they hang together and you can find a mood episode, then it becomes more clear. Now, I'll tell you, the transition from DSM-4 to DSM-5, Dr. Stahl, was pretty monumental for the field because, again, we were going from ignoring this concept or really requiring that mixed features be part of an episode rather than hanging around, that we almost never diagnosed people with mixed episodes because it was hard to find those episodes, with the recognition that a lot of patients actually experience these symptoms a lot, almost non-episodically. So understanding that is why I think we motivated ourselves to say, hey, we're seeing a lot of impact of these features. Patients aren't meeting criteria, but we have to capture it somehow. So in DSM-5, we began to see the acknowledgement that these dimensional features are part and parcel of these disorders and can't be ignored.
Well, this is the Rogerism. You all know
Right.
Rogers. Roger is a clever guy that uses a lot of heuristic techniques to teach. Here are the 5 A's from Dr. McIntyre. We'd mentioned anxiety, but agitation, anger, and irritability, attentional ADHD type of symptoms. It's interesting, I tell most of my trainees that, this is an exaggeration, but that all manic patients with mania have ADHD, but all ADHD patients don't have mania. What I really mean is that there's an attentional component which is extremely common. And the problem with the 5 A's is that that's clinical, and when you start doing research and looking at the DSM-5, they don't like these things. So they're saying that the 3 most common symptoms don't count because they could occur in something else. And in fact, one of the things I know is maybe a difference without a distinction or a distinction without a difference is what's the difference between anxious depression and mixed features depression, because anxiety is probably not the only symptom those anxious, depressed people have, and so forth. But they don't respond well to antidepressants. And so the researchers are going to say, if you want to be very sure that it's mixed features according to the Bible, you can't count irritability, distractibility, and psychomotor agitation, which just seems insane. But this may help you understand the literature, because the literature, if they're doing DSM criteria for the entry of so-called mixed features, they exclude those. And so the non-DSM criteria are what you and I are going to use in every day. And we won't exclude agitation, irritability, distractibility, the so-called criteria of others outside of the DSM, and consider family history and age of onset. So if you've got somebody who's got, first-degree relatives with bipolar and they have a very sudden and early onset, watch out. So, and they're going to have agitation, irritability, and distractibility. So if you want to use the DSM-5 criteria, this is the problem. And that 4 times as many cases will be diagnosed as having mixed features if you put those 3 things in. Mm-hmm. So why do you care? Well, it has to do with specificity versus sensitivity. And if you are doing research on mixed features, you want to make sure that they really have it. And so you exclude everybody that's somewhat doubtful. And then you get that little blue thing right there. That's doing research. You and I live in the world that's not necessarily saying that all patients identified as DNX have to surely have DMX. And the problem is you're only going to get 5% of those who have it. But you're really sure that those 5% really have it. And 95%, here's the problem. The treatments for mixed features is different than the treatment for non-mixed features. Mm-hmm. And if you give the wrong treatment, that 95% aren't going to get better, or they might even get worse. So this is what we do over here. This has more sensitivity but less specificity, and do you and I care in the afternoon clinic? Probably not. Here, maybe up to 10% of patients that you think are DMX aren't. And you might end up giving them an atypical, let's say, when they might not really need it. But by the time they get to your clinic and mine, they've failed 2 or 3 SSRIs, and that's part of the issue. So the question, when you see these patients, what's more detrimental? Misdiagnosing somebody as pure unipolar when they're really DMX, and then you give them an antidepressant and it won't work or makes them worse, or treating an unidentified DMX. These are the dilemmas. You work it out the way you want to. But the consequences of misdiagnoses are
tremendous. And I think you teed this up really nicely, Dr. Stahl, in terms of the probabilistic ways that we think about. We live, as clinicians, we live in probabilities. We think about our patients in terms of this, are we going to do more harm than good? At any given moment when we're pulling out our prescription pad and we're prescribing an antidepressant, are we going to help them or harm them? And that really does weigh on us and our patients too, because when you have multiple treatment failures, it erodes trust from patients. And so you have these decades often, perhaps many, many years strung in a row, where people basically develop a bias that their medication or their treatment was ineffective. then that can lead to this vicious cycle of treatment resistance when people may even experience low subthreshold dosing of medications and not really get an adequate trial, or their response is reduced or diminished because even in the presence of an appropriate diagnosis and treatment, they've gone now years of having treatment failures. And those people who are treatment failing tend to have more side effects. So then you end up having more treatment emergent mania, more suicidality. The impact then becomes continuous and a vicious cycle that really is difficult to break. So when we live in the world of probabilities, wouldn't it be great if we could preemptively disrupt that vicious cycle, or try our best when we're thinking outside of the box, outside of this vicious cycle, to really be careful about our diagnostic considerations and maybe even think about what have we missed in that probabilistic evaluation of our patient. What have we missed?
I've never even asked you this, but I'm going to pop it on you. I've always wondered that, remember this big furor that came out with the SSRIs causing suicide, and it was mostly in children and young adults. And this was in the era, actually, before the DSM-5, or very early in the DSM-5. I've always wondered, and this is what I do when I see children and adolescents, whether or not the increased suicidality was due to the fact that these kids were mixed and given SSRIs and they didn't know it.
Yeah.
And that just spooks the heck out of me. So if you're going to see children or adolescents, even if you're an adult psychiatrist, we encourage you to see adolescents because there's such need for treatment and not enough providers. Keep in mind to actually really drill for mixed features, because if you give somebody with mixed features and antidepressants, they'll get this treatment emergent, and they may even get suicidality. Do you think that there's a possibility that if we'd gone back and done those studies and eliminated the mixed features, we wouldn't have a suicide warning on these drugs?
Yeah, I mean, looking at it from a retrospectoscope, who knows that if we had conceptualized these kids a bit differently. I mean, we're doing the same thing with trauma, too. Is everything that we saw back then, early childhood trauma and its impact? The problem with these issues that we haven't really resolved, particularly in kids, and I say this after now completing a randomized controlled trial where we gave offspring of parents with bipolar disorder escitalopram versus placebo, and kids actually in both arms improved. So there wasn't a clear-cut signal that these kids are highly sensitive. Some portion of them, guess what? About a third developed a treatment emergent mania as a consequence of escitalopram compared to placebo. But the point I want to make is that the sensitivity and specificity is still working itself out in these dynamic organisms that are changing, but are also at risk for side effects generally. Kids are just more predisposed to side effects. So we have to have that background information. That's why dosing is important. It's why we start low and go slow with kids. But the iterative evaluation of a child is just going to predispose you to doing a better job in the long run.
You know, that's the one thing that's different for me as an adult psychiatrist, a child psychiatrist, is that when you see an adult, I don't know if this is right or not, but you make a diagnosis, you kind of forget about it, and you just treat symptoms and, you know, of course, the illness. With a kid, you have to put your seatbelt on so you don't fall out of your chair. With each subsequent visit, you find out new things that you never saw before, maybe they even developed in the middle. You have to re-diagnose kids every time you see them.
But if you don't even think about the alternatives, the differential diagnosis, and that just gets back to your point, that if you're not even considering that it could be mixed features, then that's even off the table. And that's the thing I think is a really important takeaway from today's presentation, is that you've got to think about the differential diagnosis. Even if the probabilities reduce specificity, it doesn't matter. You still need to think about it. And it's consequential for kids because you do have potentially this, well, you have to manage the boxed warning nevertheless. You know, the prescription rates for antidepressants went down after that boxed warning came out. What do you think happened to suicide rates? Globally, they went up. And so, we're in a very rock and a hard place situation particularly with kids, because we don't want to put them at risk. We don't want to make things worse, but we also don't want to miss treating them. And so you have to look in the business of prescribing an antidepressant. It has to be an ongoing start low, go slow, really watch, address other additional risk factors like family history. That's why we did that trial in family history positive kids, because we wanted to know, are these kids really at increased risk? Our pilot data suggested, tons of case reports suggest that you have this almost interaction between young age and a family history that really predispose you. Jeff Strawn actually published a paper and said that 95% of kids under the age of 12, if they had a family history, developed some sort of side effect from an antidepressant. It's why, we had to be very cautious when we did this study. It was a high-risk study but that's also standard of care. What are you going to do when you don't have a lifetime history of mania, ever? In kids, that's just much more likely. You're not going to see a lot of manias, true bona fide manias. But what gets missed in that is that you don't necessarily evaluate for hypomanias. And the hypomanias is what gets you, because those are always more difficult to diagnose. Non-euphoric hypomanic symptoms combined with depressive symptoms is a recipe. It is well known that this association is related to increased suicidal risk. And the presence of mixed features increases risk for suicide by 4 times in both unipolar and bipolar depression. And if you'd believe it, over 2/3 of depressed suicide attempters are in a mixed episode when they attempt. So this is critical. This is not something that we can snooze about. It really is a consequential decision. And just to kind of elaborate on the pediatric risk factors a bit more, you can kind of see how the data play out in kids. 79% of youth with bipolar disorder with mixed features have reported some suicidal ideation, suicidality, attempts. And what might underlie the connection between DMX and suicidality is this use of antidepressants, as you were alluding to before. But it's often a rule rather than the exception that you see these confluence of factors. So young age combined with antidepressant exposure, combined with family history, end up becoming a recipe for increased suicidal risk. And then treatment emergent hypomania also is increased compared to the general population. If you've got any hypomania symptoms to begin with, and if you have, again, what are those key symptoms that show up that really, really must be evaluated for? You've got psychomotor agitation, pressured speech, language or thought disorder that really kind of rise up as common features. Now you're going to say, well, Dr. Singh, these are just aspects of typical development in kids. How are you going to distinguish that, a kid playing or being hyperactive from pathology? Remember, what hangs together is really going to give you a higher index of suspicion. You have to think about these symptoms not in isolation, but in relation to one another. And there are very interesting data to suggest that some atypical antipsychotics, as well as lithium, might even be protective in treatment emergent mania. But in kids, it's a pretty hard sell for a lot of parents to put a patient, a child, on lithium, a mood stabilizer, or a second-generation antipsychotic in the absence of any mania symptoms. So these are the factors that predispose us. The FDA has some very clear guidelines. They've got the black box warning that you have to be mindful of, that you have to talk about very, sort of circumstantially, because the evidence is still pretty mixed. It's not clear that any of the antidepressants trials showed a causal relation between antidepressant exposure and suicide. But in any case, the box warning is there. You're compelled to talk about it with your patients when you prescribe an antidepressant. But what's even more important when you're clinically interacting with your patients is to talk about how you're going to journey with them. And believe it or not, there are some very specific monitoring requirements for antidepressants, especially in kids. And we don't do it. We don't monitor nearly as much as we should.
You know why?
Tell me why.
Because, first of all, it's bull. The FDA regulates the sale of medicines. This is what a salesperson for an approved drug should tell a prescriber. The FDA does not and never will control the practice of medicine. Mm-hmm. So, as you know from the pediatric and expert guidelines, they don't actually endorse this. This is not realistic. It's not necessarily proven to help anybody. And so it's not
empirical or data-driven, right?
Right. So if someone throws the FDA, the PDR in your face and says, you're not doing this, prescriber, you can say, no, I don't sell medicines, I practice medicine. So, I mean, I think that we need to stand up for the right to do the correct kind of practice and not let the FDA intrude upon the practice of medicine. Some of this is good sense in certain cases, but I'm not sure that I think this is horrific that only 10% are doing that. It doesn't bother me.
Yeah, no, and I mean, I think it's hard to know what to do, and when you're uncertain, sometimes guidelines like this could be helpful to at least give you peace of mind or some guidance on how to keep on top of this and not ignore it. I think that, that's another takeaway from today's presentation is that we can't ignore it, and if there's opportunities for you to check in, it's not a one and done deal, and so often what we get in terms of adverse events relates to the fact that patients are given prescriptions and then signed off on. So one of the most important questions to ask any patient with depression is whether you have any hypomanic or manic symptoms, and of course also a family history of bipolar disorder. Every patient, every time. You won't miss it if you ask every time. And there's lots of tools out there that you can use to actually assess for depression with mixed features. There's a number of scales and semi-structured interviews that are listed here. And I think what's really interesting is the durability of mixed features over the lifetime of observing bipolar disorder as a phenomenon.
Yeah, you grow into them. You don't grow out of them, right?
No, you don't. You grow into them, absolutely. But look at the distribution of mixed features over the course of the lifespan. And what I was going to say is that Kraepelin knew that if you had an early onset of bipolar disorder, you were going to present predominantly with mixed features. So how should we treat it? In kids, what's really interesting is that we don't have, again, an FDA stamp or approval for specifically mixed features. We do have approval for acute manic and mixed episodes for kids, and we can talk about the landscape of that treatment in a moment, but some interesting post-hoc analyses of recently approved drugs have demonstrated that they do pretty well in covering mixed features. So when you look at patients who are randomized, this trial in lurasidone was done in kids down to age 10. With bipolar 1 depression. And if you do a post-hoc analysis of that trial, you can look to see if mixed features had any differences, kids who had mixed features versus kids who didn't, and they did great. They did about the same, and they separated.
But if that had been an antidepressant, go back one slide, it wouldn't look like that. That's the point. You may have worked in, it doesn't work well, antidepressants. They can work, like you said, even in your trial. That's the kind of just confusing thing. Well, I've given my bipolars antidepressants and they have gotten better. Well, watch out if you do that 10 times.
Absolutely.
And the more mixed features they have when they're bipolar, then you're in trouble.
You're in trouble, yeah, no doubt about that. This post-hoc analysis just drives home the point that there are options for patients who have mixed features. And what's interesting is that if you look at which symptoms are actually targeted by lurasidone and other medications, you can actually hone in using these really interesting factor analyses tools to find out which symptoms are targeted. And turns out the ones that are most prominent for mixed features, whether it's sleep dysregulation or irritability, are highly responsive to these medications in acute phase as well as long term. But what about antidepressants? Let's go back to that. Do they work? In a recent meta-analysis of 34 randomized trials testing 14 different antidepressants in youth with depression, only fluoxetine was superior to placebo. There's a strong placebo response in pediatric clinical trials, but the more important point is that you really have to be thinking more about those cases of kids who don't have any hypomania or mania symptoms that are likely to respond to antidepressants. You got to screen for mania symptoms every time. When you treat adults, what's the landscape there?
Well, pretty much the same, quite frankly. And we have the spectrum where you have all the full depression on the left and full mania on the right. And to a great deal of confusion in the old DSM, mixed meant basically you're manic and depressed, full features at the same time. And it was really a form of mania and treated like mania. It wasn't really mixed. But over here, it's true that really only the purest of the pure depressions without any mixed features get the classical reuptake blocking antidepressants. In this whole spectrum, the evidence suggests that as you have more and more manic symptoms, whether you have mostly depression with mania or mostly mania with depression, that these are the so-called second generations. Some of them have good data, some of them have post hoc data, some of them only have the same mechanism of action, but they are in this area. And that's what has been the sea change. Whereas over here you have the so-called mood stabilizers, which would be lithium and valproate. And I'm going to put this in, Jonathan Meyer and I wrote this book on lithium, and we're going to give a talk at the APA a couple weeks. We give this whole section on old drugs that no sponsors ever want to pay for. And so we did one on MAO inhibitors last year. Well, it turns out, do you know that the UK has withdrawn its guidelines to have anybody under 55 get a valproate prescriptions anymore?
Is that right?
It used to be just women of childbearing potential. The changes in epigenetics are so profound, it ruins men's sperm for it's not the problem with teratogenesis and so forth. It's not just once the baby is in the womb, it's once the sperms are in the womb or whatever, in the bag or wherever they are. And so...
are we going there?
Are we going there? But when you say mood stabilizers, it's turning out, wow, valproate is disappearing. It's not yet in the United States have such severe warnings, but no new starts of valproate in the UK, for example. So that the mood stabilizer has come to mean lithium. So please learn about lithium. It's a great drug if you know how to use it. But only those patients with essentially no hypomanic symptoms should be given a reuptake blocker. Now, the ones that have these unipolar with mixed or bipolar with mixed, the best evidence is coming out of the atypicals. Now, a lot of people don't like them. Some of them are expensive. They all have some side effects, some bad side effects that people don't want. One of the worst things that we're working on is to change the name. NBN stands for neuroscience-based nomenclature. I'm a co-chair of an international committee to try to stop people calling these things antipsychotics. Yeah, how many of you had this experience where you give a patient who's doing poorly, maybe even with mixed features, one of these agents, and they come back and say, "Doc, oh my God, you think I'm crazy? I looked it up. Why are you giving me this antipsychotic? Am I nuts?" And he said, no, you're depressed. They said, oh. So we want to name it for the mechanism of action, and many have shared mechanisms of actions. But we're finding out that the so-called atypical antipsychotics are doing, if not, if you will, randomized prospective studies, they're doing some post hoc analyses, and guess what? The reuptake blockers, in another talk, which you don't have time to do here, but I'll give you a hint, they don't work very well in anxious depression either. So when you have patients that don't respond to your SSRI, and then, or give them another one. And then if they don't respond, you might give them a third one. And then if they don't respond, you give them an SNRI. And then it is time to take a history. I mean, I can't believe, I have to admit that how many times it's been, you have anxious features? Oh, yeah. Oh, geez. You have mixed features? Oh, geez. So the atypicals work there. They have their problems. Some of them are expensive, but they have good data. The other stuff doesn't work. And unfortunately, nobody's done enough work on the lithium. But you could look at this table. Some are approved, some are not. But basically, we treat with atypicals and not with reuptake blockers. So the FDA-approved ones are here.
For kids, yep. And what you see is that there's still some unmet needs in this area. If you looked at the previous graph, you notice MMX for mania with mixed features. That's really the gig that we have for kids. We have acute mania and mixed states. This is pre-DSM-5. Most of these studies were done before that. And so we need to still understand, how do we effectively treat mixed features? So common in kids, and yet we don't have any FDA approvals for it.
So, I mean, people in child, I've noticed, are much less eager to do, let's say, off-label.
Yeah.
They want to go on label first. Now, I'll give ourselves, there's a new book coming out that Jeff Strawn and I did, a shameless promotion. We actually just have a child prescriber's guide, and if you want what's approved, it's in bold print.
Yep.
But there's almost nothing approved in child for bold compared to adults, so what do? Once you've tried the ones that are approved, you do nothing, or do you actually go to the NEI conference, listen to Dr. Singh, and do what's rational and prudent and works in trials that are not yet at the level of approval?
Yeah, no, well, we're working on it now in terms of lumateperone, for example. There's a pediatric trial that's underway to understand its efficacy and safety in kids. And we already know that it's been approved for adults. If you'll notice that it's been approved in adults with bipolar II disorder. We do not have any approvals in pediatric bipolar II disorder yet. And I will tell you that in general, I tend to diagnose bipolar disorder pretty infrequently in kids. Maybe it's because I'm indoctrinated to the idea that hypomania and mixed features are just not feasible. But what I typically see patients coming in with in the clinic are 2 to 3 days of hypomania, not 4 or more.
Give me 4. Come on.
No, I just can't do it.
One more.
I can't.
I want a diagnosis. Come on.
You're unspecified.
Ah, geez. I was that close.
So then when you don't see it, you don't take care of it, you don't treat it, and then the cycle continues. And we do know that lumateperone at 42 milligrams significantly improves symptoms of depression and disease severity in individuals with MDE associated with bipolar 1 and 2, with or without mixed features. Again, you see this pattern of post hoc analyses that demonstrate if you look at the presence or absence of mixed features, you have similar efficacy profiles, and you also have similar safety profiles. Those second-generation antipsychotics are not going to cause treatment-emergent mania. Same true for asenapine. You see, again, a separation, not just from placebo, but from olanzapine. And in asenapine, in mania with depressive symptoms, again, this idea of thinking about these treatments more on a continuum of everything the patient has, a very holistic perspective of them, and you can see the separation. And same true for cariprazine for DMX and bipolar 1 patients, as well as lorazepam. And what I think is really important in all of these efficacy studies, and then we'll end on, we've got olanzapine monotherapy in the treatment of bipolar depression with mixed features. Olanzapine fluoxetine combination is actually approved in kids for treatment of bipolar 1 depression, but it's always a tricky enterprise to be exposing kids to antidepressants, especially if in the presence of mania and without any opposed mood stabilizers. Quetiapine is another one that's approved for bipolar 2 in adults, and you can see the very clear separation from placebo, both in depression severity and overall global functioning. As well, important to understand that it works well for depression, but doesn't work so well or significantly separates from placebo on mania severity. So there may be some differential effects of these pharmacological agents on...
It looks like a class effect, doesn't it?
I do think it's a class effect, yeah. Ziprasidone, similarly, you've got unipolar or bipolar DMX, improvement in depressive symptoms, but not improvement in mania. So tolerability, just a quick point about this because we're running out of time. We've got amazing, clear understanding of what second-generation antipsychotics do efficaciously, but we also know that there's liabilities associated with them, most commonly sedation, weight gain, and extrapyramidal symptoms, and this is a nice graphical depiction of the relative weights, I guess you could say, of each of these. And so if you have to make some choices, picking your agent of choice for patient conversations is important. And off-label prescribing of antipsychotics is important to understand that we don't want to do that in kids. There seems to be a very important risk for sudden death, in kids. And so one thing to keep in mind is really use the lowest dose possible in kids to treat pediatric depression and avoid using antipsychotics with high metabolic risk. And now that we have the opportunity to understand this metabolic risk in kids, we're now thinking about adding adjunctive metformin. There's a large PCORI study that demonstrated that it looks like, and the first cut of the data have yet to be published, but it's looking like, a second-generation antipsychotic in kids with bipolar disorder must be accompanied by some sort of metabolically impacting drug as well. Mood stabilizers. Surprise, there's no mood stabilizer approved for use of depression of any kind, either unipolar, mixed, or bipolar. I think you all know this, that there are some data for the efficacy of lamotrigine or valproate for bipolar depression, and we know that lithium has great anti-suicidal effects, but neither lithium nor carbamazepine monotherapy is really recommended for bipolar depression. We know that lithium is very effective. I appreciated the call out, and I think Dr. Meyer's monograph on lithium is exceptionally well written and gives a really nice deep dive onto the use of lithium, which I think is underutilized.
Unbelievable, yeah.
Right?
Well, particularly with the death of valproate and the side effects and expense of the atypicals, I think lithium is in for a rebirth.
Yeah. So, any final thoughts on antidepressant monotherapy? We did a pretty quick tour.
Well, I think the answer is no, if you know it's DMX. Then the other question would be don't. And then, of course, if you're seriously, you just don't do it. And then again, antidepressant should probably not be used with hypomania, and you won't know unless you ask, of course.
Are you sure?
So every patient, every time, I don't know, I think they come in and they have like a little, thing on their forehead that says I'm mixed, but if they don't have that, And one thing we didn't really mention is that lumateperone has done a post hoc analysis, and Roger and I have done that with a poster. We didn't put it in because it's not actually published yet, but also seems to work post hoc for mixed features.
Nice.
So in summary, the accurate diagnosis is crucial, and besides that, you should make a diagnosis, and then after you do that, you diagnose them. Otherwise, the anxiety, agitation, anhedonia are helpful. Misdiagnosis can make you give a reuptake blocker when they need probably an atypical. So treatment options such as lumateperone now, I should have mentioned perhaps more, olanzapine, lurasidone have shown efficacy post hoc mostly. Antidepressant monotherapy for DMX should be approached with caution, can work for some people, and sometimes you add it on to an atypical, but usually not as monotherapy. Lithium stands out and it needs to do more comeback.